John Weigelt, your coordinating editor for CSAP 17 Audio Companion. I have asked Dr. Walter Pofall, one of our CSAP 17 authors, to speak with me today. Walter, first of all, can you share with our audience where you're located, your primary focus of your clinical practice, and maybe a little bit about how you spend your usual day, if you really have one of those?
Sure. I appreciate the opportunity to participate in this project. I'm in Greenville, North Carolina. I'm a faculty member at the Brody School of Medicine at East Carolina University. Been here 19 years. I'm a general surgeon by training, and general surgery still makes up approximately half of my practice. So regular old bread and butter general surgery. And then the other half is head and neck endocrine surgery. So I was blessed with great training and have a great opportunity to practice this. And I feel like I've honed my craft and art over the years. You know, my typical day, I'm in the operating room 2 days a week, in the outpatient office a day and a half per week. I do my own ultrasounds. We have an outpatient surgery center where I am 2 days per month. And then I have some other administrative responsibilities, but the bulk of my time is on clinical care.
Well, that's great, Walter, and I just want to emphasize that expertise in endocrine is what we're going to lean on today, and I can assure the audience that I've been totally impressed with your contributions to our discussions as we develop our questions in the endocrine category. So we really will be discussing topics from CSAP 17 that are from the endocrine category. Now, some of the topics actually come right from the CSAP 17 questions, but others will be from questions that were written but not selected for the final draft of CSAP 17, but the discussion of them is stuck in my brain, and I hope to get your ideas about some of those discussions as we carry on our discussion this morning. So let's get started. And I had a very interesting discussion with one of our graduating residents last year who got confronted with a question in the certifying exam on Graves' disease. So let's start with Graves' disease. It's a condition that I thought that had sort of drifted away from surgery. So let's review what are the suspicious clinical signs that a surgeon might notice in a patient that they're just observing for some other reason.
Right. And so I think you need to take it even a step backwards, and you have to look at patients who present with hyperthyroidism. Now, Graves' disease is the most common cause of hyperthyroidism, but amongst patients with hyperthyroidism, clinical symptoms, tremulous, tachycardia, heat intolerance, atrial fibrillation is much more common in older patients and can be a presenting sign. So when you have patients who kind of meet those criteria, you really need to start thinking about, is this patient hyperthyroid? Obviously, the physical signs associated with this, things like tachycardia, atrial fibrillation, a goiter, or tremulous, even help guide you down the pathway for evaluating hyperthyroidism. And fortunately, the evaluation of hyperthyroidism is, fairly straightforward. It's measuring thyroid function tests, and, there are a number of very good review articles and guidelines for thyroid disease. I would direct the users of CSAP 17 and the listeners of this to the American Thyroid Association site. It's got a whole list of guidelines, many of which were developed in conjunction with surgeons and relate to the topics. But, the long and short of the evaluation of hyperthyroidism is, clinical suspicion, then using basic laboratory data, specifically a TSH and a free T4. And if both of those are the TSH is depressed and the free T4 is elevated in a patient with those symptoms, you've got your diagnosis of hyperthyroidism. And then to establish the diagnosis of Graves' disease, that typically involves the antithyrotropin antibodies.
And once we've got a diagnosis of Graves' disease, is this still a surgical disease, or are most people treated medically?
The vast majority in this country, in fact, worldwide, are treated medically. And the first step is symptom control. Everyone with symptoms, or virtually everyone with symptoms, should be put on a beta blocker. And then the initial step is managing the hyperthyroidism, which is typically done with antithyroid medications. And this is in adults, and then you have to, the vast majority of these patients are non-pregnant, but patients who are either pregnant or planning pregnancy, it's a little more complicated, a little in terms of differences in the antithyroid medication agents. But in this country, methimazole is the preferred antithyroid medication. It has a lower side effect profile for the non-pregnant patient.
You mentioned the goiter and a diffuse enlargement, I'm assuming, but are we still seeing hot nodules as the cause of hyperthyroidism?
Yes, yeah, you can. I mean, and toxic multinodular goiter is, reasonably common also. So in a patient who's hyperthyroid, who does not have TSH activating antibodies, TSH receptor activating antibodies, then you start thinking about, well, is this a toxic multinodular goiter? Is this a solitary nodule, or is it some, autoimmune thyroiditis, Hashimoto's thyroiditis? And again, those are patients who benefit from radioiodine scanning.
And if you're going to operate on a patient with hyperthyroidism, is there still a regimen that you go through to get the patient ready?
Yeah, I mean, the first is to control the hyperthyroidism, both with the symptoms and the adrenergic response with beta blockade, and then the hyperthyroidism with antithyroid medications. There's been debates back and forth about the efficacy of saturated potassium iodine solution, and some of the more recent data suggests that the incidence of hypoparathyroidism is less with saturated potassium iodine solution. And so most people use it. The side effect profile is low, other than the fact that the stuff just tastes awful and patients really don't like it. But other than that, many surgeons use it.
And you said the Lugol's was to prevent hypopara, or is it hypothyroid?
The theory has always been that it caused some gland involution, less bleeding. And again, the literature's gone back and forth on that. But some more recent data suggests that the incidence of hypoparathyroidism is lower afterwards. But again, none of these are, large randomized prospective trials.
And that's essentially because it, in theory, makes the technical aspects of preserving the parathyroids easier?
Possibly, yes.
There was another discussion of a question that did not get into CSAP, and that was about thyroid eye disease. What's that?
The same process that is autoimmune process that's causing Graves' disease also accounts for what's now called thyroid-associated ophthalmopathy, of which Graves' orbitopathy, if you will, is at the far extreme. And so where you're getting influx of inflammatory cells and inflammatory products, which causes hypertrophy of the fibroblasts and the myoblasts. And that's, again, this orbit, similar to the skull, is a confined space. And as those hypertrophy, you get proptosis, with the eyes being pushed out. And again, this is along a spectrum with, dry eyes, tearing, irritation, if you will, to the far extreme with the severe proptosis. And so most of these patients can actually be managed medically, fortunately with controlling their hyperthyroidism. Smoking cessation is a big component of it, and medical management with glucocorticoids. Really, on the far end of the extreme, are you getting into things like orbital decompression?
All right, well, let's move on to another topic that most general surgeons face routinely, and that would be thyroid nodules. And let's first talk about a diagnosis. So you mentioned guidelines for hyperthyroidism. There are some new guidelines for investigating thyroid nodules since the last CSAP edition. Can you give us a rundown of what might have changed?
A constantly changing area in the evaluation of thyroid nodules is risk stratification. And so the most recent guidelines really rely heavily on ultrasound for risk stratifying thyroid nodules. And also the radiology literature and the radiology practice has now even migrated to, there's something called TIRADS, which again is a point system, and that in the ATA, the American Thyroid Association guidelines in terms of their risk stratification actually match up pretty well. And we're seeing more and more nodules now. I mean, someone can't walk into the ED with a cough without a chest CT that then detects a thyroid nodule that then leads to an ultrasound, which then leads to the finding of a thyroid, characterization of the thyroid nodule, carotid duplex, the same thing. And so the nodules, are characterized, benign, very low suspicion, intermediate suspicion, and high suspicion. And each of those has kind of a range of risk of malignancy and recommendations, regarding biopsy. Things that are benign are lesions that are purely cystic and really, don't need a biopsy in the absence of symptoms. And this extends all the way up to lesions that are highly suspicious, and those are things which, as you can imagine with any malignancy, have, irregular borders, microcalcifications, things that make you worried about extrathyroidal extension. And those, certainly a biopsy is warranted, if they're a centimeter or greater. And then the intermediate suspicion also at a centimeter or greater. And then once you get into the other categories, which are kind of mixed cystic and solid or isoechoic or hyperechoic, not necessarily need to be biopsied at centimeter, but rather anywhere from about 1.5 centimeters in size.
So this classification system with using ultrasound is similar to the BI-RADS that we use in breast diseases?
Correct. Very similar.
All right. You mentioned biopsy, but are we really talking biopsy, or are we talking fine needle aspiration?
Fine needle aspiration biopsy, correct. So, so the classification, there is what's called the Bethesda system for classifying thyroid cytopathology, has really been standardized. In fact, there was an update in 2017. And this is it's really classified the taxonomy for how these are reported out. And I would certainly encourage, anyone who does thyroid surgery to really work with their pathology department to make sure that, this taxonomy is used, because, it's very helpful. It's helpful with, having conversations with your patients about what are the implications of these biopsies, rather the biopsy results, and helping you figure a path forward. So I think that is really simplified things. So nothing drives me battier than having a consultation from an outside source, and the pathology report or the cytopathology report says, atypical cells seen. And so, well, what does that mean? So we frequently review that. Obviously, I'm in an institution where we do a lot of this work, and so really benefit from that. In terms of the accuracy, that's the other thing that people have to, really be cognizant of is, what are the predictive statistics in your institution? So something that is, atypia of undetermined significance, at an institution that does a lot of this, the risk of malignancy in general is 5 to 15%. But if you're at an institution that doesn't do a lot of it, those statistics may be different. So it's very important to have a working knowledge of what that is at your institution.
Now, the Bethesda system, if I remember correctly, has got 6 categories. The first 2 are fairly benign. The highest 2 are fairly consistent with malignancy or have a high rate or risk of malignancy. And then there's this category 3 and 4 in the middle that are suspicious but not definite to have a high enough malignancy rate to force your hand for operative intervention. So what do you do with a 3 and a 4?
So the indeterminate lesions, there are a number of different approaches. The current approach, you have to take into consideration, not only the biopsy results, but what are the patient factors? Because there are additional ancillary tests, specifically molecular markers. But if you have a patient who has a 5-centimeter nodule that is indeterminate on biopsy, the risk that is going to be a thyroid cancer is reasonably high enough that, virtually everyone's going to recommend a resection. And most people, in point of fact, for that would recommend a total thyroidectomy. And certainly if the patient is symptomatic, you're going to do a thyroid resection. So molecular markers have, added to, in some situations, complicated our decision-making process for this. And there's a lot of, misinformation for patients because none of it's intentional, but it can be a confusing area. Again, I see plenty of patients who believe they have a thyroid cancer when they don't necessarily. So, we've got a protocol where, if someone has an indeterminate biopsy and the appropriate factors, then that is set off for molecular markers. There are several commercially available products here. We use a type which is called a gene sequencing classifier. The trade name for this is Afirma. And so that's what's called very good at a rule out test. So it has a very good sensitivity. So in terms of if it is reported out as benign, the chance of that is a thyroid cancer is fairly low, or I should say negative. It's fairly low. Unfortunately, some of these return as suspicious, and then we know that the risk of malignancy is about 50%. So I certainly tell patients that conversely, that means that the chance that this is a benign lesion is about 50%. So everyone, like I said, many people come and they're convinced they have a thyroid cancer and really worry about it. And then this particular commercial product, then if it's suspicious, also looks for specific mutations. And the most common one in papillary thyroid cancer being the BRAF mutation. There are other mutations that you can find, like NRAS, but those can be seen in benign lesions. So I use this to guide the conversation with the patients. So my approach to thyroid nodules is, if I'm going to do a thyroid resection and I've got a concern for malignancy, what would be the adequate operation if this is a thyroid cancer? So if it is a small intrathyroidal lesion, no evidence of extrathyroidal extension, no abnormal lymphadenopathy, no suspicious contralateral nodules or even nodules that might need to be biopsied in the future, then a thyroid lobectomy is appropriate. But again, you have to take into account, what are the patient's wishes? You have to have that conversation with them and, their expectations. And then you also it's a multidisciplinary approach. So if this is a thyroid cancer, best practice is involving endocrinologists, and you have to know what your local endocrine resources are, what their practice pattern is, and kind of how it all fits together.
All right, well, let's take a couple of specific lesions and see how we need to think about these. So you have a woman with a 3-centimeter thyroid nodule, and on FNA you've got a definite papillary thyroid cancer. what pre-op evaluation is necessary before taking the patient to surgery?
Obviously, I mean, a detailed history and physical. And I mean, I do focus on risk factors, family members who may have had thyroid disease, specifically thyroid malignancy. The days now of patients getting head and neck radiation for, enlarged thymus or tonsils or acne, those patients are fewer and fewer. So radiation exposure isn't much of one. I think it's also important to assess for, are there any symptoms that make you suspicious for local invasion dysphagia. And so, obviously, evaluating someone for a thyroid operation, you proceed with a general preoperative evaluation as you would for any patient. But in general, these are low risk operations. I do, a detailed head and neck ultrasound, that really gets a good look at both the central neck nodes and the lateral lymph nodes is, very important because that can really change your approach. And it's pretty well documented that intraoperative assessment of the lymph nodes is nowhere near as accurate as ultrasound. That's probably the most beneficial. It tells you, the cancer, is it totally intrathyroidal? Where is it located? I've got a very low threshold for doing preoperative laryngoscopy for patients with, thyroid malignancy. I mean, virtually all of them. Certainly larger thyroid nodules, even if they're benign, and I'm planning on doing a thyroid resection, they're going to get laryngoscopy. So I do it selectively, but I've got a very low threshold. And then ultrasound also, again, if there's extrathyroidal extension, such as strap muscle involvement, that will help with your operative planning. So in general, when you're operating on thyroid cancer or presumed thyroid cancer, there really shouldn't be any surprises. So you shouldn't be surprised by strap muscle invasion. You shouldn't be surprised by obvious, metastatic lymph nodes. And certainly, based on the location of the lesion and the size of it, you shouldn't be surprised by recurrent nerve involvement. So all those things, that's where I really think that ultrasound, is very important.
The surgical procedure for a papillary thyroid cancer without any ultrasonic evidence of nodal spread is what?
Well, that's there's some debate about that. So, golly, I finished my training in 1994. So 25 years ago? I mean, the whole debate was total versus lobe, and then it swung all the way over to total, and now it's back to, total versus lobe. And for a patient like this, the conversation that I have with them is, there's the tumor biology, obviously, and we'll get to that in a minute, but, what's going on in the contralateral lobe? Are there a bunch of nodules in there that are going to have to be biopsied and followed? And if the patient's willing to undergo that, no problem. How do my local endocrinologists treat these? What's their expectation? And certainly with the understanding of patients who has a 3 centimeter thyroid nodule, there is some increased risk of recurrence with just a lobectomy. But if you look at long-term survival, I mean, it's equivalent. And so if it's, a low risk lesion, meaning no abnormal lymphadenopathy, no extrathyroidal extension, then a lobectomy is a reasonable operation. I can tell you, I mean, like I said, I'm blessed to have this as part of my practice, and I'm taking care of patients who have had small thyroid cancers. Interestingly, they tend to be, in my experience or anecdotally, tend to be young patients, but they've got, lymph node metastases and in some cases recurrences. And these are small lesions. And then I've got other patients who, have big thyroid cancers, and you take them out and, you get the yearly, I get follow-up from our endocrinologists and nothing, no recurrences. So it's a matter of tumor biology. So that's kind of a long-winded way of saying, tumor biology has a lot more implication than the operation I do. So, if a patient is reasonable, is able to follow up, knows the importance of it, then a thyroid lobectomy is an acceptable operation. A lot of patients, though, they just want their whole thyroid out. That does make them easier to follow clinically with, thyroglobulin levels and ultrasound.
So, Walter, let's talk about another area that has gone back and forth, and that is a prophylactic central node dissection. Where does the American Thyroid Association stand on this?
Yeah, you've got guidelines and you've got people's, practices, and even within the endocrine surgery community, there's practice variability. This is an area, there will never be a randomized prospective trial on this. But we do know risk factors that increase the risk of central neck nodal metastases, and that's tumor size over 4 centimeters and extrathyroidal extension. For me, anyone with that is going to get a central neck node dissection. So when folks who are listening to this, you go to the literature and it is documented that the risk of hypopara and recurrent nerve injury is higher. But again, these are studies, it's similar to any other procedure, like hernias. The stuff that's reported in the literature are folks in general doing a lot of this. And so those results may not be the same results that someone who is a less frequent thyroid surgeon gets. So that's something that people really need to kind of keep in the back of their mind. But my practice is, prophylactic central neck dissection, again, for patients with tumors over 4 centimeters or extrathyroidal extension. I have colleagues that I know who do it on pretty much everyone. But again, I think the results, the literature, and stuff, support, my position just as well. And occasionally you do have to reoperate on folks with central neck node recurrences, and that can be challenging.
So you do a lobe, you do your central node. Do you use thyroid suppression postoperatively?
So I only do a prophylactic central neck dissection if I'm doing a total thyroidectomy. If I feel there's a need to do a central neck node dissection, then then their tumor's over 4 centimeters, or they've got extrathyroidal extension. In both those cases, total thyroidectomy is indicated for prophylactic. Anyone who's undergoing a therapeutic central neck node dissection, meaning they've got clinical, radiographic, or biopsy-proven metastatic disease in their central neck nodes, they also get a total thyroidectomy.
So in your lobes, though, do you use thyroid suppression?
No.
No.
Do not.
Okay. And how do you follow that patient then for the potential of recurrence?
Yeah. So folks, again, like I said, I'm blessed to work with a really good group of endocrinologists, both here at the university and in town, who, they drop into a follow-up program, which involves periodic ultrasounds. And even patients who've had a lobe will get a baseline thyroglobulin level and then track that over time to see if it's rising.
Okay, so how about if we switch the pathology to a follicular thyroid cancer? Same pre-op workup, more, less?
Pretty much everything is the same. So both being differentiated thyroid cancers, folks pretty much treat them the same in terms of their preoperative evaluation and even their operative therapy. So it used to be that, if a follicular thyroid cancer were up to 2 centimeters, you'd do a total thyroidectomy. Now, there's not much benefit. There's no benefit really in treating it different than papillary thyroid cancer.
And again, the decision for a neck dissection in any of these cases is based upon your pre-op ultrasound?
Correct, based on the pre-op ultrasound, right. And if they're abnormal central neck nodes, it's nice to have a biopsy of those preoperatively, but if you can't, then I certainly, if they have suspicious ultrasound characteristics, then I'm just going to treat them as if they're malignant.
Okay, let's switch then to medullary thyroid cancer. What cell is the precursor to this?
So it's parafollicular cells, which are neural crest cells.
And is this a sporadic tumor, or is it related to a genetic defect?
Well, about two-thirds of them are sporadic, and then one-third are inherited through an inherited disorder. And of that, MEN2A is the most common. So I tell the students, just remember, two-thirds are sporadic, one-third are inherited, and of the one-third that are inherited, two-thirds are MEN2A. I mean, the percentages aren't exact, but yeah, the majority are sporadic, but you do need to kind of evaluate every patient ideally for an inherited disorder. Ideally, these patients undergo genetic testing, but having recently dealt with this, I mean, some patients opt not to undergo genetic testing, which is unfortunate because if they do have a genetic syndrome, then it's autosomal dominant with a high penetrance. And so they are really putting, siblings, children, at risk. And this is one of those syndromes where intervention early can make a difference. The treatment of the surgical treatment from the standpoint of the medullary thyroid cancer is the same, whether or not it's sporadic or inherited.
And that treatment option is total with central node?
With central neck node dissection, correct, because the incidence of central neck node metastases is much higher with the medullary thyroid cancer and the clinical implications of it. And also, you really need to have a low threshold for doing lateral neck node dissections. Again, the incidence of jugular nodal metastases is much higher with medullary thyroid cancer.
And follow-up of these patients is done how?
Pretty much the same. The major difference being these patients, again, since this is not a follicular cell-based lesion like papillary or follicular thyroid cancer, but rather parafollicular cells, you don't need to suppress them with thyroid hormone. They do not need radioiodine. And an important component for this is if patients present with medullary thyroid cancer, again, like I said, we need to be thinking of inherited syndromes. And if they do have MEN2, then you have to evaluate them for pheochromocytoma and hyperparathyroidism. If they refuse genetic testing, then definitely they need to be checked for pheo and hyperparathyroidism. So again, I had a guy just last week that I operated on that we really thought that he had it. The biopsies looked like it. He did not want to undergo genetic testing. He had that and hyperparathyroidism. So we treated him as if he had MEN2A. We ruled out pheochromocytoma, but then the operative treatment was geared towards managing him as if he were an MEN2A.
Well, one other type of thyroid cancer that hopefully none of us ever have to see is anaplastic. Can you give us some idea? Do you always have an idea that this is present once your pre-op workup is done?
It can be challenging. Occasionally we'll see patients who will have an incidental anaplastic thyroid cancer, and those are usually very small lesions and you're operating for another reason. When we see patients who have rapidly growing neck masses, very large neck masses, it's really the growth pattern. And then on examination, these things really tend to be firm and fixed. That's when we really start worrying that this is an anaplastic thyroid cancer. And establishing the diagnosis can be challenging because, again, there's a lot of fibrosis. And you really have to take a rapid multidisciplinary approach. And I have found, at least in our institution, that we end up actually bringing these patients in, as a kind of an outpatient observation status just to get their workup completed in a timely fashion to get, folks on board seeing them. And it's really a bad disease, but the first step is making the diagnosis, and sometimes that can require open biopsy.
Well, before we leave thyroid and move on to the parathyroids, just a generic question, because I've seen a number of articles in the literature, not only related to neck operations, but in general, all surgical operations. And that's, what do you do when your patient is on antiplatelet drugs? Do you have a plan for that, or do you worry about that, or you just say, well, we'll go ahead and we'll be extra careful as we achieve hemostasis?
We stop all antiplatelet agents and all anticoagulants. A couple of years ago, I mean, there was a multi-institutional trial that looked at this that found that patients on either any of the antiplatelet agents or anticoagulation had a much higher risk of neck hematoma, and the consequences of a neck hematoma obviously can be pretty significant. Unfortunately, it really didn't get broken down, between the novel anticoagulants or the other antiplatelet agents and aspirin. Kind of our National Quality Improvement Program now, when we enter cases, it specifies antiplatelet agents versus anticoagulants. So, but yeah, I stop them. For everyone I know stops them for thyroid operations because, again, I mean, it, proceeding along, thyroid surgery, obviously you want, in general, it's, I won't say bloodless, but I mean, it's not a bloody operation. Again, these agents can really lead to problems with bleeding. And then, again, intraoperatively identifying critical anatomy, the recurrent nerve and the parathyroid glands, it's challenging enough, as is without adding, some extra bleeding in there. But more importantly, it's postoperatively. Again, a patient gets a neck hematoma. So if things go well with these patients, we resume their agents pretty quickly. Typically, I typically do it the following day or the day after that, within 24 to 48 hours. And part of their preoperative evaluation is, why are they on these agents? If they're on it due to cardiac issues, working with their cardiologist to figure out, an appropriate plan for managing it. And there are a lot of people who are on these agents who in reality, probably don't need to be.
Well, let's move on to parathyroidism. And first, how about a quick description of primary, secondary, and tertiary hyperparathyroidism?
Sure. So in primary hyperparathyroidism, the process is being driven by the parathyroid gland. So you've got hyperfunctioning parathyroid tissue elevating the parathyroid hormone, which then elevates, in the vast majority of cases, the serum calcium level. Secondary, there is some other source which is stimulating the parathyroid glands. Far and away the most common is end-stage renal disease, chronic kidney disease on dialysis patients, where hyperphosphatemia, hypocalcemia, low vitamin D levels, all stimulating the parathyroid gland to where they have hyperparathyroidism. They just don't. Again, these other factors are stimulating the parathyroid gland. And then finally, tertiary is where patients who've had secondary hyperparathyroidism, and that has resolved. Again, the scenario being someone with secondary hyperparathyroidism undergoes kidney transplant, their renal function is normal, they're off hemodialysis, and they have persistent hyperparathyroidism. That's the way I kind of put these in the different buckets. And if you think about a nomogram where you've got the parathyroid hormone level on the x-axis, the calcium on the y-axis, do I got that right? And up there in the right upper quadrant is primary hyperparathyroidism. The parathyroid hormone level is high, the calcium level is high. In the left upper quadrant, the parathyroid hormone level is high, but the calcium is low, and that's secondary.
Let me just try to simplify things, or maybe I can, maybe I can't. So if the calcium is elevated and the parathyroid hormone is elevated, is anything else needed before surgery is scheduled? Isn't it really easy, or am I missing some confounders in making this diagnosis?
Yeah, in general, I mean, you've established the diagnosis of primary hyperparathyroidism. But certainly, yeah, I mean, you do need to, before you proceed with operation, you have to decide, well, why am I operating? What's my rationale? I mean, because not every patient with primary hyperparathyroidism needs an operation. My feeling is the vast majority of them do and would benefit from an operation. But, obviously you've got your general, preoperative evaluation like we talked about for thyroid disease. I do think it's important to measure a vitamin D level and make sure their vitamin D is repleted. What's their level of renal function? Because again, these are all factors that may not necessarily impact a decision to operate, but can certainly help, looking at another reason why the patient might benefit from an operation, and also, discussion with the patients. And not everyone with hyperparathyroidism fits the classic thing where their parathyroid hormone level is, 200 and their calcium is 12. We see a fair number of patients whose parathyroid hormone level is quote unquote normal. But again, there's a very tight feedback mechanism in calcium regulation, such that if your calcium level is elevated, your PTH should really be suppressed. I mean, less than 30 or even 20.
You mentioned vitamin D. Now, what about familial hypocalcinuric hypercalcemia that everybody talks about?
Right, FHH, very rare. It's
that's why we talk about it.
That's right. It's rarer than medullary thyroid cancer. So you should suspect it in patients who have family history. I mean, so it's autosomal dominant inheritance, and then the diagnosis of it can be challenging, I guess. So the best way to do it is a 24-hour urine calcium, and you look at the calcium, the creatinine clearance ratio, and you do want to make sure that their vitamin D is repleted before you do this. I mean, you're looking at calcium to creatinine clearance ratios of like 0.1 or so. So I mean, it's very low.
So in other words, it's just good fodder for test questions.
Right. The typical patient coming in for evaluation for, surgical management of hypercalcemia due to primary hyperparathyroidism, I don't do urinary testing unless there's a question about the diagnosis. And then, so patients with hyperparathyroidism fall into kind of two categories. You have symptomatic patients. We use a symptom scoring sheet to help, objectify that. It's something that one of my colleagues at Emory developed. And so we use that. So if they have symptoms, then virtually all those patients benefit from an operation. If they're truly asymptomatic, then you have to decide, well, what are my indications for operation? And specifically, if their age is under 50, although I will tell you, as folks are living long, majority of these are females, so who have a longer life expectancy. So that's under question whether or not 50 is the right cutoff, but we know that patients who are 50 years of age or younger are more likely to develop complications of hyperparathyroidism. And so typically those patients are offered operation. Anyone whose corrected calcium is greater than 1 above normal, would benefit from operation. The bones are a target organ, if you will, for primary hyperparathyroidism. So anyone with osteoporosis on bone densitometry, and it's regardless of the location. And then the other target organ, as I tell patients, is, their kidneys. So folks who have creatinine clearance of less than 60, I just use the estimated GFR. You have to be careful with that as patients get older. Obviously, their GFR goes down. And then if they don't meet any of those criteria, I'll do 24-hour urine calcium. And if their 24-hour urine calcium is more than 400 milligrams, they benefit from operation.
Let me ask you a practical question, because there is a CSAP question to emphasize just what you said about a younger patient who is totally asymptomatic that benefits from a parathyroidectomy with asymptomatic hypercalcemia, and that is, do you put those patients through a workup so that you know what their bone density is before you go through? Obviously, you'll know what a creatinine is, etc. But is age enough to pull the trigger?
Yeah, age in and of itself is enough with the diagnosis. Yeah, and bone density. Yeah, I mean, I certainly try and get them, scheduled and get that taken care of. in my practice, I mean, most of these patients are coming to me through endocrinologists or my primary care network who has a good working knowledge of this. And so in general, those patients have already had bone density testing done. But if it hasn't been done, then yeah, I certainly make sure it gets done sometime in the perioperative period.
Well, let's talk about surgical approaches. I'm going to assume you use localization tests of some sort. So what's your favorite?
So my favorite is actually ultrasound. So again, I do my own neck ultrasounds. I've been doing them for 2 or 3 years. And so I start with that for 2 reasons. Number one, thyroid nodules are common. About 15% of patients with hyperpara will have a thyroid nodule that you need to biopsy. And so I sure want that information up front. The last thing I want to do is go in and do a parathyroid operation on someone, and lo and behold, here's some nodule, and I'm thinking, wow, is this going to be a thyroid cancer? Like I said, thyroid surgery, you don't want any surprises. I guess that holds for all, neck surgery, parathyroid surgery included. So ultrasound is important to rule out associated thyroid nodules. And then localization. In centers that do a lot of this and are really good at it, I mean, their localization rates with ultrasound are just as good as Sestamibi. And so that's my other ancillary that I use is Sestamibi. It's a radionuclide study. It's taken up by the mitochondria, metabolically active tissue, and it preferentially washes out of the thyroid quicker than the parathyroids. We've got a really good nuclear medicine group here, and so I've got a pretty low threshold for that. If I have a patient who has obvious hyperparathyroidism, calcium is greater than 1 above normal, on my ultrasound there is an obvious adenoma, that's the only localization study I will do.
But if the ultrasound is not clearly localizing, then Sestamibi?
Then I go to Sestamibi. Some of those will have adenomas in the upper mediastinum, which, again, depending on the patient's neck anatomy, may be difficult to see with ultrasound. I'm pretty convinced that we're not the only place with patients with large, short necks, but sometimes I think that. So yeah, I don't rely on other ancillary studies, specifically multi-phase CT, commonly referred to as 4D CT, for de novo operations. Unless there's something atypical about the patient, again, very difficult neck anatomy, I'll utilize that. Certainly anyone who's having a reoperation, very important that you precisely localize. As I've gotten more comfortable with ultrasound, I've relied on that more and more as my sole localizing test.
And when you are doing this minimally invasive approach to remove that parathyroid gland, I'm assuming you're also using intraoperative monitoring, correct?
Right. So I use intraoperative hormone levels, and I actually use it on all patients. So and again, as a referral center, I see a lot of patients whose studies don't localize. And again, the localization studies are only used for operative planning. I mean, they're not establishing the diagnosis, and they're not saying which patients, should undergo operation. They're just helping with your operative planning. And, everyone loves it when you've got an obvious adenoma and you go in there and you take it out. It's one of those hero cases. But you also have to be able to take care of the patients who don't read the textbook, so to speak. And again, we see I would say at least 30% of my patients don't localize or have really high suspicion of multi-gland disease. And so even in those cases, again, where I'm doing full neck explorations, I do use intraoperative hormone levels. Absolutely. And there are other techniques. I mean, that some people use gamma probes, so radio-guided surgery, but I would say that the vast majority of folks use intraoperative hormone levels.
And when you're doing that open neck exploration where you think you've got multiple gland disease and they all look about the same size, do you implant? Do you dice it up and implant someplace? And where's your favorite location?
So if someone has primary hyperparathyroidism and they've got multi-gland disease, like you said, I mean, it's important to identify all four glands. If that patient has four-gland hyperplasia, in general, what I do with them is I do a 3.5 gland resection and I leave a remnant. I try and leave it as an inferior parathyroid because that tends to be the most remote from the nerve. That way, if it regrows, it's easier to go after that without being at risk for injuring the nerve. If I need to auto-transplant it, I'm going to auto-transplant it in the forearm in a patient who has hyperparathyroidism. The reason being, that stimulus for hyperparathyroidism is going to be there when I'm done operating. And the last thing I want to do is me or someone else at some point down the road have to go back into their neck and try and sort out, where is this, recurrence. And even in the sternocleidomastoid muscle, I mean, it's just really hard to dig through that. So that's why if I have to auto-transplant in a patient with primary hyperpara, it goes in the forearm. If I'm doing a thyroidectomy and one of the glands is devascularized or I can't peel it off the thyroid lobe, those are patients where I'll auto-transplant it into a pocket in the sternocleidomastoid muscle. But yeah, you're right. You mince it up and you just put the pieces in.
How do you manage symptoms of hypocalcemia post-op, or don't you get them?
It's unusual. I send patients home on, prophylactic calcium. They have instructions to where, look, if you get some numbness and tingling in your lips or your fingers, take some extra calcium. I send them home on 500 milligrams twice a day. We write them a prescription, but we tell them, look, just get the over-the-counter stuff. Just that I find that if they have a prescription, they treat it as a medication, not as a, oh, yeah, he said get some Tums. Well, I don't have any indigestion, so I really don't need it. So, yeah, and occasionally, folks will have it, especially, folks who've had a higher calcium and they're used to, walking around calcium, so to speak, that's much higher. And suddenly, you bring them back into normal calcium homeostasis and their calcium level, drops, say 4 points. Yeah, they may get some symptoms, but again, we've found that by just prophylactically giving them some calcium around the time of the operation, in general, really haven't had any issues.
And how long do you use the supplementation?
Typically just for 2 weeks. So when they come to see me, stop it, check their serum calcium, done.
Let's talk about I don't know if it's tangential. It's a similar problem, but for some reason it was a favorite question in CSAP 17, and that was about malignant hypercalcemia. And it seems like there's been a shift in treatment approach, whether it's new drugs or whether it's whatever. How do you manage malignant hypercalcemia these days?
I mean, some of the mainstays still hold. I mean, and that is, starting with the simple stuff like, hydration. Well, number one, these folks, need to come in. A lot depends on the acuity. So it is just fascinating how high some people's calcium can get if it's chronic. And again, it's just amazing. I mean, and whereas if we'd acutely raise our calcium that high, I mean, we'd be dead. But yeah, so they get admitted. We start with hydration and do some nice saline, diuresis if they can tolerate that. If they can't, then you can add a loop diuretic, but you have to be really careful because if you dehydrate it or you go a little overboard on that, then that can actually worsen it. Calcitonin is great because it can really drop the calcium pretty quickly. The unfortunate thing is, again, its effectiveness is only for the first, day or two. And so typically these patients also get administered reclass or zolenjolic acid. So it's a bisphosphonate, so it inhibits osteoclast. So those are probably I would say kind of our mainstays. As a surgeon, I don't typically get involved, for hypercalcemia of malignancy. Occasionally we'll see patients where there's a suspicion for parathyroid carcinoma. The first step is to get their calcium level down. And also sometimes seeing patients who, again, have long-standing primary hyperparathyroidism. For some reason, they get dehydrated, they get significant hypercalcemia, they end up in the hospital. So that's another group of patients that we'll see. But usually it's pretty easy to differentiate those folks from hypercalcemia malignancy.
And what about the use of Sincalcet?
So, yeah, I mean, it's a calcimimetic for the calcium-sensing receptor. For folks who, again, have bony metastases, driving their hypercalcemia, there's really no benefit. For those who have a paraneoplastic syndrome with PTH-related peptide, then yeah, it does have a role there. It's an agent that's used much further down the line.
You mentioned the business about diuretics. There seems to be a fear of diuretics now. Hydration first, and then the idea was always to add a loop diuretic on that to further increase the excretion. But it seems like we've moved away from that. Is that a fair statement?
You have to be thoughtful about it would probably be a better statement. Again, and it just depends on how much folks can tolerate the volume. Again, many of these patients have underlying congestive heart failure or other medical conditions, and many of them end up getting loop diuretics. So I mean, we're pretty cognizant of it. So we've got a pretty low threshold for using them. Absolutely.
Let me ask about another related topic with hypercalcemia that usually raises its head in the skin and soft tissue category of CSAP-17. But this year we did not have a question on it, and that is calciphylaxis. What is it?
So it's an unusual condition, and it's calcification, the dermal arteries and adipose tissue. I mean, it's calcification in the media of the vessels, and I mean, it's virtually always associated with end-stage renal disease. I mean, those are the only patients that I've seen it in. I mean, and these are painful skin lesions that are difficult to manage, and the mortality associated with this is pretty high. These are patients who, to begin with, aren't healthy. It's not necessarily the calciphylaxis kills them, but I think it's more of a marker for their underlying condition.
And is it a complication of secondary or tertiary hyperpara?
It's a complication of secondary, definitely. Because, some of the risk factors are, again, chronic kidney disease on dialysis, patients who have hyperphosphatemia, and those are, typically the patients that it's seen in. The treatment is, we've got a wound care center here who's actively involved, so, managing the wounds. I mean, biopsy is important, as minimal a biopsy as you can. I mean, you really have to be careful with debridement because, again, you can debride and, then you get calciphylaxis in the residual tissue and you can end up debriding back and more and more and more and more. And I mean, it can be a real bad disease. And then, trying to control their risk factors. Obviously, you can't control their dialysis, but, controlling their hyperphosphatemia, managing their vitamin D. And then there was a study a couple of years ago that found that patients who have calciphylaxis and secondary hyperparathyroidism may benefit from parathyroidectomy. So again, a couple times a year, I'll see patients who have that, who I do perform parathyroidectomy on. And that's the other thing is, for patients that I see for secondary hyperparathyroidism that are being considered for parathyroidectomy, I always ask them about, skin lesions and stuff like that.
So what has your success been with doing the parathyroidectomy in that patient with calciphylaxis?
In terms of reversing their calciphylaxis, it depends on the extent of it. Some patients can have very small lesions and it helps. I think there are other factors, but for me, I think it is a reasonable indication for parathyroidectomy in a patient with end-stage renal disease.
Let's move on to another endocrine organ, and that is adrenal. And another favorite question in CSAP-17, and probably in everybody's practice today, is what do I do with an adrenal incidentaloma? I guess maybe we should define that, but I know it's a problem facing many general surgeons when an abdominal CT scan is done, and lo and behold, there's an enlarged adrenal.
Right. So an adrenal incidentaloma actually, has a definition. It's just a mass lesion over a centimeter, discovered, be it a CT scan for abdominal pain or trauma, an MRI, ultrasound of the kidney, you name it, you discover it, and it's not something that can be ignored. I mean, the vast majority of these are not issues. And so the two issues that you do have to worry about is this malignant? Okay. What is my suspicion that this is malignant? And that's, a function of its size, and that's a function of its radiographic appearance. And then the other consideration, is this a functional lesion? And again, the majority of them are non-functioning. The majority of them are not malignant. So adrenocortical carcinoma, fortunately, is unusual.
So let's do a pretend here. So I'm your trauma surgeon, and I've got let's call it a 48-year-old male who was involved in a motor vehicle crash, and he got an abdominal CT scan. He really has no injuries, but he's got a 2-centimeter lesion in his right adrenal gland, and I'm calling you up and I say, so what do I need to do now?
My first step in that is, detailed history and physical. This is 48, so again, unlikely that it's a metastatic lesion, but any symptoms that would suggest, any of the functioning syndromes, pheochromocytoma, Cushing's disease, hyperaldosteronoma. And so these pathways occur concurrently. I look at the CT scan, is it less than 10 Hounsfield units, in which case virtually always benign. And then along the secondary pathway is this functioning? Everyone should be screened for pheochromocytoma because, again, it can be paroxysmal. I typically start with 24-hour urine for metanephrines and catecholamines. And then patients, mainly their examination, do you think they have Cushing's? And then it's just a 24-hour urine-free cortisol. People go back and forth about whether or not all these need to be screened for primary hyperaldosteronism with, plasma aldosterone and renin activity. And then adrenocortical carcinoma is more based on the radiographic appearance.
Okay, so we've done all that, and everything is negative, and I've got to go talk to this patient and tell him what we're going to do about this. Do we follow it? Do we tell him, no, don't worry about it, just go about your business?
Yeah, I think it is reasonable to follow these. If it's benign, someone like this, 2 centimeter, I'd probably repeat the CT scan in 12 months. And if that looks normal, then probably another 12 months after that. And if there's been no change, then I think you're done.
So my radiologist says MRI is better than CT scan. What do you think about that?
I don't think that's the case, but it gets down to, what's your radiologist's comfort level? What is their practice? What are they used to looking at? And in that case, it's like, fine, MRI it is.
Well, Walter, I see our time this morning is up. It's been a pleasure sitting here discussing these various endocrine questions with you, and as usual, your answers are succinct, and I'm sure will help many of our listeners on CSAP Audio Companion. As usual, I end this with giving my author the opportunity to make any comments they wish to add about CSAP, the process, the use of it as we go forward with lifelong learning. So you're up. Number one, I appreciate the opportunity to participate in the last 2 versions of CSAP. I found it really to be, great benefit. I've used it every time I've gone for recertification, and to me, I've found that that's been,
very helpful. Obviously, the recertification process is changing. Obviously, there are other resources that are available to surgeons and all physicians. And, my style of learning when I'm getting ready for examinations that are going to ask me questions is to use a tool that asks me questions. When I've participated in the process of writing these questions, I have learned a lot. And you've always been really good about giving us stuff that's outside of our comfort range, so to speak, because we're treated as if we are general surgeons. And so we do write questions outside of our specialty, but we've got folks who are there who are specialists who really, we as a group, in the different committees, work together to make sure it's the most current knowledge and that it's the right knowledge. But I think I'm not a trauma surgeon, but when I write questions about trauma surgery, I write them from the standpoint of, hey, if I have a buddy who's a general surgeon who's practicing out in Edenton, North Carolina, what does he need to know about this condition? What's the right approach, as opposed to, writing a question about some esoteric aspect of, thyroid cancer that, someone who doesn't have a practice that I have is going to encounter. So I think it's a great resource.
Well, I appreciate those comments. It's always fun to participate in each of the committees. And as I said, the discussion is great. Maybe someday we'll just record the discussion, and that'll be CSAP 17 audio companion. So
that would be interesting.
Again, I thank you for spending time with me this morning, and you have a nice day.
Thank you, John.
That's it for this category of the CSAP 17 Audio Companion.